bring an image for you. That image, I think, will be self-explanatory. And there we are looking at a muscle. Which muscle is present in the front of my chest wall? This muscle is famous with the name of Pectoralis Major. And you'll be learning about this muscle when we'll be starting our MSK. Now, if you look at the fibers, guys, before going into the detailing, there are so many concerns, there are so many things, but what we are trying to provide you guys is the main, basic, and very essential contents. If you want to go into the research part, I will show you today how many further types of muscles are there. And what has been discussed with you is the mostly commonly to be known, must know type of information. Otherwise, if I go into the minutiae part, then the sky is the limit and I need months and months to complete one single task. And a simple advice for you, we see here, everybody who's sitting gonna be a good physician. So to be a good physician, there's a level of learning. And further, you want to add on with your learning part, then you have to be having more and more details. And we'll try to go more in clinical perspectives. Obviously, this is the basic general anatomy, and general anatomy, you may ask me, where is the clinical, what you're talking? I'm trying to bring a little bit, but it's not that much. But inshallah, after when this block is over, we have a lot of interesting material and we are ready to deliver it to you. Now, if you look at this muscle, what has been very obvious here, just focus on, look at the fibers, as we said, they're coming from one place and they converge. Look at, this is a section. This shows to you. But this is an example of a convergent. And look at it. This is another example where I call it multi-pennate. Now look at it. Within this muscle, which is deltoid, and there are small units. And these units are primarily bipennate variant and they are embedded together. And now this description, this type of arrangement, we label it as multi-pennate. And here they are just one direction. There is no such coupling in between. You can just compare this section with this section, and there you can see the organization. So that's a basic difference. Let me try to put more examples for that. So it's the same question which is there, and then look at it, the deltoid, and you can see the pattern, how this pennate pattern is being formed. Look at it, compare with the convergent part. The fibers are going straight. Only they are converging to a point, but they are straight fibers. Another form, only we are not talking about convert, this is spiral. And there are so many variants. And this multi-pennate, look at it, the pattern. So many such units, they are joining, they are converging to a point. Now, going back, what you should know about muscle, but before let me show you something more. Look at it. These are just muscle, we haven't talked about them. And you're looking at, from the side, a fusiform, a biceps, a triceps, a quadriceps. So these are variants. Then I have, these are the parallel, and then different variants which are there. So there's an army, there's a big range of things. But what we need, you guys should be focused on specific points which are relevant for your better understanding. So don't put your time for these. If you have that much extra time, do something, even go relax. But you should be targeted. You should be expected to know what is a must-know type of information. Don't push yourself for undue things and which has no really clinical relevance unless you are doing a PhD in some kind of muscle fibers. So now look at this. How many shapes are there? Did we talk about them? We only touch about this one. We talk about these unipennate, multipennate, bipennate, and that's it. But there is a big list of the things. When you open textbooks, you will find so many. But advice is, don't. If you want to play, then play in a full show. Otherwise, single shot is not recommended. Anyway, so my today's topic will be regarding the joints. Before starting, let me ask you a question. What do you understand by the term joint? I will come to you. Just raise your hand. Okay. Yes, I can see you. Can you stand? Last on female side, the second row. You raise your hand. Yeah. Okay, anybody from there? Speak loud. Can you go to a mic? If you are thinking there's a question, rush to a mic. Otherwise, and I want someone. Do you have a mic here or no? No, I will. Person is here or is gone? Okay, I'll check with him. Mic is here. So, what do you understand by the term a joint? Union of two bones. You want to say something different? What is your answer? Speak in the mic.
It's for two bones meet.
Thank you very much. So you are saying the place where two bones meet. I am agree with you and I'm not agree with you. Why I am agree with you? Because you're right, but there are other elements. The place where two skeletal elements meet, that is a joint. It could be a bone to a cartilage. It could be a cartilage to a cartilage. That has also been said as a joint. Anyway, so my objectives are today, this is the major objective and there is another one. So we'll be going around these objectives. And now the definition, what I was asking, the site where two skeletal elements, structures come together. That we call it as a joint. If you're saying bone to a bone, perfect. Bone to a cartilage, perfect. Cartilage to a cartilage, perfect. Are we good? Now, before going to the detailing of joints, we are expected to be good. We are expected to be familiarized with certain terminologies, and they are associated strongly. And these are, when you study about joints, this specific part of the learning, it's been put under the heading of arthrology. Arthrology is a science where we are learning about joints. Then the second term is kinesiology. And this is the study of joint biomechanics. When we'll be going in depth detail of a joint, where we'll be talking about biomechanics, it means we'll be learning more about, and that science is kinesiology. And then we have fracture, trauma, disease. So these are another important part. And then arthritis. Guys, in front of every name, if we add ITS, it means infection, inflammation. Arthritis means infection of a joint. Appendix, appendicitis, it means inflammation of the appendix. Any organ, stomach, gastric, gastritis, inflammation of the stomach. Pancreas, pancreatitis. So this is how it goes. And then we have, and there are so many types of that, septic, rheumatoid, like we'll be learning about them in MSK, not now. And then another term, osteomyelitis. Once there is an infection within a bone, a bacterial infection which is located within a bone, the term which has been favorable for that is known as osteomyelitis. The word osteo is always referring to a bone. And then a very commonly occurring situation which has been there for a joint, for a bone, and that is either it can fracture as an outcome of a trauma, or it can be dislocate. Dislocate means they go apart. The bones who should face each other, they are not present in their normal situation. And then the last, when it could be interchangeable, both can occur together. Like after a trauma, somebody can have only fracture, someone can have a dislocation, someone can have a fracture and dislocation. So it's possible. Don't think that way. Only fracture can happen or only dislocation can happen. Are we good? Yes. What is first two? Can you read it? You can read it yourself. For kinesiology is written study of the joint biomechanics, and that is study of joints referred to. So broad picture is arthrology. When we are learning everything about joint, like today we are talking about joint, this is arthrology. Now in arthrology, I have kinesiology. It's an underheading, subheading of that. Are we good? Now, joints, the picture which comes in our mind when we are looking at a joint means the place where two skeletal structures, they meet with each other, where two bones meet each other. So the functional aspect. What is happening at this joint? There are three options. Option one, they are joining with each other, but there is no movement. And broadly, we have bony, fibrous, and primary cartilageous joints. And what we have? Immobile. Joint is there, but there is no movement. Can you give me an example of such joint? You have that joint and you don't see any movement. Yes. Can you speak loud? Within the skull, there is something called suture. I have an image I'll be showing to you. So the skull suture, it doesn't move, but I disagree with you. It moves. And when it moves, can you tell me the timeline? And it moved for all of us. What time it was moving? Who will tell me that? Speak loud. Never. Okay, after year 20, you think you're expecting your skull will be dancing? It's not happening. Yeah. At birth, excellent. When we were all born, the skull sutures, they have not fused together. Why they have not fused together? Because if they were fused, your head could have stayed as much. But when they are not fused, so they can overlap. And this overlapping of skull bones is called molding. And this molding will decrease the size of your skull, and that will help your mom to expel you out, to go for the process of childbirth. So it is a helpful act and it is useful, and that is called molding. You know, we usually use the term molding, something you can accommodate. So it's a molding. And this is the place where these skull bones, they are overlapping each other. But after birth, they come aligned and they fuse, and then they never move. And the second variant, the joints, there is some slight degree of movement. So slightly mobile. First categorization, no movement. Second categorization, there is some movement. And third are freely movable, like I'm doing this at my shoulder. Circumduction at my shoulder. Flexion, extension, I'm moving freely. There is no problem. Nobody is stopping me. So you should be able to appreciate what is something which is not moving, what is something which is slightly moving, and what is something which is freely moving. Yes. It's coming up. Sabr. Are we good so far? Now, I'm taking the first example, the fibrous joints. Fibrous joints are primarily famous for no movement. Those who fall under this category, these joints, we don't find any movement. And examples, we have talked about them. And the first example which was mentioned, it was the skull suture. So we call it suture. It's one example of a fibrous type of a joint. The second one, your tooth. Have you ever seen your tooth moving? Yes, it moves when it goes wiggly, and then it's been out. When you are a baby, your tooth got wiggly, your milk tooth were gone. Does it happen or not? Have you encountered that? So that time they go wiggly and then they are replaced by the permanent tooth. So tooth are another example, and it is a name, we call it gomphosis. And the third variant of a fibrous joint, the place where my radius and ulna meet, and in my leg where tibia and fibula move. So these are the location, and it has a name, syndesmosis. So these are three locations which are an example of a fibrous type of a joint, and there is no movement at all. Are we good? Have you seen? Can you demonstrate any movement within your teeth? Your teeth can move around, dance. Today is here, tomorrow is here. No, it never moves. It's fixed. And the day it starts moving, within 2-3 days, it's gone. Then you have to visit a dentist for an implant. No, it is fixed. There is a periodontal ligament which keeps it fixed and steady. Otherwise, you're having something hard and you're trying to crush on that, and you can see your tooth is also being thrown out. So tooth never moves. So these three are the examples. What are the examples? Number one, suture. Number two, gomphosis. And number three, syndesmosis. And I've shown you the names and I've also shown you their respective examples. Are we good? Okay, now we are looking for the second category, and second category joints are cartilageous joints. The cartilageous joints, we divide them further into primary and secondary cartilageous joint. And what are the differences and what are their examples? So now you're looking at, in this image, you're looking at primary cartilageous joint. The first joint location, you can see what you're looking at. We talk about it in detail when we're talking about the features of a typical long bone. Look at this epiphysis. Look at this metaphysis. And this was the epiphyseal plate. And this epiphyseal plate, when it fuses, it's done. No movement. You'll never see head of the bone, head of the long bone moving over the metaphysis, over the shaft of the long bone. So it is one of the example. Another place where my rib meets with the cartilage. And these two are the examples. Example one is union of my epiphysis and metaphysis. Dotted line is a representative of that. And originally it was a cartilage. And once the two ends, you have achieved the age 20 plus, they are fused. And then you cannot find it even if you go in a lab, you take a real bone, you cannot see where is the epiphyseal plate. It is inside. And then the second example, the union between the rib and the costal cartilage. These two are the examples of primary cartilageous joints. Are we good? Then let's talk about secondary cartilageous joint. Secondary cartilageous joints are mostly found in the midline of my body. In the midline, I have a joint, a secondary cartilageous joint, the place where one segment of my sternum, my chest bone, it meets with another segment. So the manubrum part where it's meet with the body, that is manubrosternal joint, one. Second, in between my vertebrae, where we have a disc, two. Third, where my pubic symphysis, where my two pubic bone, they meet. So these joints are located in midline. This is their very peculiar point. And you may have slight movement. Primary cartilageous joint, you don't have any movement. But secondary cartilageous joint, you have a movement, but it is hardly visible. It's very slight, very light. So this is the example which I've said to you, the disc between the two vertebrae. You heard this term a lot. Oh, someone has a slip disc. So this blue thing is that disc which usually slips out, it herniates, and then the person cannot even stand straight, and person can be subjected for surgeries and so many other modalities. Now you're looking at a real picture of the same, someone's spine, and you can see this whitish structure in between this. This is the disc. Are we good so far? So we have seen what? The joint, the place where two skeletal elements they meet. We divide the joints into three variants: fibrous, cartilageous, and synovial. Fibrous, completely, there is no movement. Cartilageous, primary, there is no movement. Secondary, there is slight movement. And synovial, freedom of movement. Are we good? Now, looking at a synovial joint. Let's try to label it first. You're looking at the two bones. What is so important within these two bones who are facing each other? What is so particular about these two bones? Yes. Yeah. They are not hitting each other. Any other thing? Faisal, you want to say something? Yes. I cannot hear you, man. The mic is close by. Why don't you stand and speak out? Speak in the mic. No? Yeah.
It's a synovial joint.
Yeah, it's a synovial joint, but my question was, what is so special about these two bones? These two bones, thank you, Faisal. These two bones are made for each other. Their surfaces are congruent to each other. It's not like one bone is like a cone and other bone is like a circle. So if you look at these surfaces, they are designed that They are made for each other. And when we use the term made for each other, the right term is they are congruent to each other. They are aligned with each other. Their chemistry matches with each other. So they can get along. And then we'll talk about they are lined by this cartilage and that all other things. Now look at this is the lower end of a bone above, and this is the upper end of the lobe. So both of the images are showing you epiphyseal part of a bone. Now let's label it shortly. So you can see this medullary cavity. We all know what is there in the medullary cavity. You can see the spongy bone. I'm sure everybody is good with that. Compact bone, you can differentiate now. How a spongy bone, it differs from a compact bone. And then what is this? A capsule, a bluish fibrous structure. It has to join. It has to cover a synovial joint. If a joint is not enclosed within a capsule, it will not be called as a typical synovial joint. We may call it a modified one. And then you can see there is inside, there is a membrane. We call it synovial membrane. Why we need this membrane? Because this membrane makes a fluid. That's a lube. It's not like your car that after a little bit, you get a message on the screen of your car, go and get relube or add engine oil. No, our engine oil is being continuously reproduced. And who's making it? Within the joints, we have these synovial membranes, and these synovial membrane, one of their integral part is making this synovial fluid, which makes it's a very viscous, gel-like substance, very slippery. And you never heard a sound coming from your joint. And the reason is the force behind is presence of this synovial membrane, and this synovial membrane, it liberates a fluid. We call it synovial fluid. One job done by this synovial fluid, it acts as a lubricant, and it has other functions as well. They are coming in my next slide. Are we good so far? So each joint cavity, not the surfaces of the bones, each joint cavity is lined by synovial membrane within the fibrous capsule. Then we can see there is fluid inside, there is a cavity, and then these two bones, they are lined by a specific type of cartilage. Why we need a cartilage covering the surfaces of these bones? Why we need a cartilage? Speak loud. To reduce friction, to make it possible for freedom of movement. My dear, wait, inshallah. At end of November, we'll be talking about knee joint, and I'll be asking you this question, cruciate, and then we'll be talking about ACL and PCL and what happened and what not happened. And I'll be talking about happy and unhappy triads at that day. I remember that. Okay, guys. So now let's construct a synovial joint. So now you can see there are two bones. Look at their surfaces. Are they congruent to each other? Are they made for each other? Okay. Now let's put the structures here. What is happening? Both of the surfaces, you can see that they are lined by a bluish structure, which is the hyaline cartilage, guys. Synovial joint. If I change this hyaline to fibrocartilage, it will not be called as a typical synovial joint. This is a characteristic. The articulating surface of the bone means the lining cartilage of my epiphysis should be lined by hyaline cartilage. Are we good? Then what is happening next? You can see one. Each bone is covered by a sheet, and that sheet is highly vascularized sheet, and we talk about it. That was my periosteum, a pain-sensitive sheet. Are we good? And then what do we have? We have this gray structure, and that is my fibrous joint capsule. It is a must. And then internally, you can see this bluish thing. That is my synovial membrane. Are we good with that? Now, within this joint space, where is my joint space? This space. Within this joint space, there is a fluid. This fluid is called synovial fluid. And from where it's coming? Are you going to a shop, or you going to a factory, or going to a panchari store to put some oil in my joints? Does it ever happen with you? So this synovial membrane is making this fluid, and this fluid is viscous. It makes the surfaces comfortable. It's make the facilitation of the movement. You can never hear a sound when you make flexion, extension, or anything at any part of your body. Are you good? So this is my synovial cavity with synovial fluid. Going further, there are certain joints. In between, we are provided with some extra pads, not every joint. And this is a fibrocartilageous pad. And where we have this, gentlemen, can you tell me now, the one you are asking about cruciates, it's for you now. What should we call this purple thing, which has been visible to you? What name you suggest for that? It is very close to your cruciate thing. No? Guys, this is called, you want to say, Faisal is raising his hand. Faisal, you answer it. Get, answer it. No, it is a meniscus, but I want a technical name for that. Now, meniscus, I'll say not. Now you'll say medial, then I'll say no to medial, you'll say lateral. No. Meniscus is an example of that. But technically, it is called as fibrocartilageous disc. And fibrocartilageous disc within my knee joint, where we have your cruciate ligaments, that is called meniscus. We have two, one is medial, one is lateral. Are we good? So this is my intra-articular fibrocartilageous disc, and it is not present. It is not present in all the synovial joints on very special occasion. Why we need this? Why we need this disc? You know, all the places you have so many bones, everywhere the bones are together. So what is the, why we need this here? Shock absorber. The reason, the maximum weight, you are standing all the day, you are dancing, you are jumping, you are doing this and that. So this is a big shock absorber, and we need it badly. And a certain individual, when this disc has a problem, that person is being said, you are unfit for this match. Go and get it done. Get a surgery done. Are we good so far? So these are the classical features which are associated with a typical synovial joint. Plus, there are more features. It should be covered by the ligaments and the muscles, and there should be some reasonable movements occurring at this joint. Then we call it as a typical synovial joint. Somebody was raising hand here. Yeah. What? Remember, this joint is available. I have examples coming up. This joint is available, synovial joint, we have so many. But knee joint is a special synovial joint which has this disc. There is another joint, I'm talking to you. With the joint, temporomandibular joint. I'm eating, talking, this joint, it also has this disc, which we are using the most, where we are having the pressure. Pressure when you're eating your food, you're cutting it, you're churning it, you're crushing it. So you need a disc here. You're standing, jumping, dancing, you need a disc in between. Other places, we don't have that much developed disc. Yes. Yeah, it's a general name. Fibrocartilage. Fibrocartilage is this structure who makes it. And then if it's in the knee joint, we call it meniscus. In the temporomandibular joint, it has another name. So meniscus is an example for that. Okay, guys. So what are the characteristic 6 features? If a joint have these 6 features, it has been said this is a typical synovial joint. The first is that the articulating surfaces of the bone should be lined by hyaline cartilage. If there is no hyaline cartilage, it will not be called as a typical synovial joint. Point number 1. Number 2, this joint should be enclosed in a capsule. You saw it before. Number 3, there should be a joint cavity. And this cavity should have, this joint should be covered by externally or internally by some ligaments. They are holding the things together. That is also a characteristic feature. And then this joint cavity should be lined by synovial membrane. Why? Because it has to make the synovial fluid. And the 6th point, this joint should be capable of bringing different type of movements. So if some joint has this 1 to 6 characters, is being liable to set as a typical synovial joint. And if someone doesn't follow it, we call it atypical synovial joint. If cartilage is replaced by, hyaline is replaced by fibrocartilage. Now we'll not be calling this synovial joint as a typical synovial joint. Now we'll be calling it an atypical synovial joint. Are we good so far? So you should be able to differentiate what are the characteristic feature of a typical synovial joint. And if any joint does not follow this point 1, 2, 3, 4, 5, 6, we are allowed to call it you are atypical. Yes, gentlemen. Yes. Yeah. See, you are a human being. You have to have a specific number of chromosomes. If 2, 3 plus minus, will you be called as a human? It will be changed. Same is happening. So anything to be called as a typical synovial joint should have 1, 2, 3, 4, 5, 6. If anything is missing or anything is extra, then we can call it simply, oh, you are atypical. Are we good? Okay, guys. So now synovial membrane, I talk about it. We know about it. Now let's talk about what are the functions of synovial fluid. We learned that it's a lube, provides lubrication. It nourishes the chondrocytes. It supplies nutrition. How? I think I'll leave it when I'll be discussing with you the knee joint. At that day, I'll be talking about it. And third, it acts as a shock absorber. And every person has taken this point and you have said yourself. Are we clear with these 3 points? Can I repeat the second one? It gives nutrition. Nutrition to what? Nutrition to my fibrocartilage disc, meniscus. Now, we can classify a synovial joint in 2 variants, either on the basis of its shape and appearance, second, on the basis of its function. So let's categorize it. Shape and structure, one way of classifying, and the function of the joint, second way of classifying. Let's look at the detail. This is what synovial joint is, a freely movable. We said a lot more time. I need not to read it. You can read it yourself. Now, plane joint. What is this plane joint thing? Look at the picture. These 2 surfaces, they slide on each other. Now, someone like to ask where I find this joint. This plane synovial joint will be found where? In between the tarsal bones of your foot and few of the carpal bones of your hand. That is the example. And it has been written here in between your metatarsal and few of the metacarpals. Are we good? Okay. The second variant is a hinge type. What do you understand by the term hinge? A door. It opens. This joint works like that. Look at my hand. My forearm moves on that. It is a hinge type. Look at your own knee. It is a hinge, but that is little bit different hinge. So you are looking at an elbow joint, a classic example, and you can see how it moves. Only one direction. This is another picture which clears your concept. And this is the bony section, which shows me the elbow joint. The joint between my humerus and ulna. So that is a humero-ulnar joint, elbow joint, or we call it hinge joint, and that is one of the variant. And the second I mentioned about knee joint. Knee joint also, you can bring flexion and extension at your knee joint, but this is not a classical hinge joint. we call it a modified hinge joint, because at knee joint, you have flexion, extension, and there is little bit rotation also. So that's why it is being categorized as a modified hinge. It's not a classic hinge. Are we clear? Have you seen when you are, can you see yourself, you can bring some rotation at your knee joint? Have you noticed that? You can rotate on your knee joint. And it's really important. Locking and locking, lower limb will be talking. Now, a most freely movable joint is an example of ball and socket type of synovial joint. What is this ball and socket? You can see there is a ball. Can you see that? And you can see there is a cup. So this ball freely moves. So where you can find this joint in your body? Shoulder. And another example? Hip. Excellent. You guys are pro, mashallah. So this is an example of a hip joint. You can see that. And this is the shoulder joint. Are we good? So this is an example of a ball and socket joint. Yes. Gentlemen, when you say a question, say it loud, because I want you should be heard in that corner. I doubt somebody is listening there or not. That's another issue. Yeah. My dear, all these plain synovial joint, hinge synovial joint, pivot synovial joint, ellipsoid synovial joint, ball and socket synovial joint, saddle synovial joint, these all are the different types of synovial joint. Some I'll be talking on, when we'll be talking about the functional part, but all of them, where are these all of them? Look at this. I'm starting again for you. This is the first example of a synovial joint, plain. This is the second example of a synovial joint. They are only moving like a hinge. The third variety of a synovial joint, ball and socket. Are we good? Yeah. See, you are a human first, and then this human can be from US, can be from UK, can be from Germany, can be from Africa. But are they all humans or not? Perfect. So all of these are subtypes of a synovial joint. Are we good? Okay, saddle joint. It's also a type of a synovial joint. Saddle. How many of you had a chance to ride a horse? MashaAllah. Can you sit on the back of a horse without putting a saddle? You can sit down, but go for 1 hour, and then we will keep you for 1 week in the bed and you cannot even stand up properly. Have you experienced that? Even with a saddle, with a lot of cushioning, your inner thighs are really hurting. So this saddle is that type. So where is that saddle? Look at it. This is you, your 2 legs, and you're sitting on the saddle of which is located on the back of the horse. And you can move this way and you can move this way, both. So the axis has been shown, either this way or that way. Another example, another image rather, showing the same character. So the joint who looks like that, we call him saddle type of synovial joint. Where I can find my first carpo-metacarpal joint, my thumb. You're saying, yes, you did it. So this is all occurring where? At the saddle joint, and this is where it is located. I'm sure you can see that. Look at the bony surfaces. They're exactly like this. Is this right or wrong? So this is the description. Now the ellipsoid. Ellipsoid is a modification of ball and socket. These are ovoid surfaces. Look at it. The ball and socket both are a little bit oval. And now they are making ellipsoid. Where I can find my wrist joint. That is a classic example of an ellipsoid type. Guys, there are so many examples. I'm just quoting simple, easy, basic examples. Don't bring, oh, you have not mentioned. I'll give you the books, you can find out a lot of them. So look at, these are the two bones of your forearm. You're looking at the radius and you're looking at the ulna. And then these are the carpal bones. Look at it, the radius and the ulna, and these are my carpal bones. And this joint is a classical example of an ellipsoid type of synovial joint. Pivot. Yeah, you can do this or you can do this. Bye. Come. These are the two things you can do. Flexion extension and side to side. If you are putting this way, ulnar deviation. If you are putting that way, radial deviation. Yes. Circumflexion you can also bring here. Ball and socket, the appearance. We are doing what? We are talking about classification of a joint on the basis of their appearance, on the basis of their shape. Yeah, because the ball and socket, ball has more freedom. This has less freedom. Pivot. I'm sure everybody had a chance to go on merry-go-round when you were a kid. So this is an example. You're heading these rights. So at your neck, I'm saying no, 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 no. This is the atlantoaxial joint. This is a classical example of a pivot. And the other one is at my elbow, I'm bringing this supination and pronation. That is another example of proximal radioulnar joint is also responsible to give us pivot example. Are we good? Then summary, you can see that ball and socket. You can see that there you are looking at what? You are looking at a pivot. You can see the ellipsoid. Gentlemen, can you see the difference between this green thing and this red thing? Hello? You're asking me this question. Now look at it. This ball and compare this ball. Is there a difference? This is the ellipsoid. This is the saddle. This is the plane. And this is your hinge. All what we have said, these all are the subtypes of a synovial joint. Now, we can classify on the basis of function. One way, two way, three way. One way, uniaxial. Two way, biaxial. And there is no three way, multiaxial. So, uniaxial, at my elbow and at my proximal radial. Even you can find other example for uniaxial. Biaxial, at my wrist, flexion extension, ulnar and radial deviation. Biaxial. Multiaxial, your shoulder and your hip. Are we good? So what we have done, we have classified the joints on the basis of their appearance. And we subdivided them into this much variants. You are shown all these examples from ball and socket to ellipsoid to pivot to saddle. Yes. What's yellow one? Yeah, this is the carpal between in the plane joint. They slide on each other. You cannot get something extra within that. Any other question? You have to speak loud. What is the difference between this one, ellipsoid and saddle? Look at it. This is an ovoid thing, and this is something which has a dip inside. It's a bean shape. It has a dip inside. Are you good? So we talk about these. Now, this is a complete detailing what we have said so far. Guys, there are, oh yes, these are within the joint, we talk about, there is hyaline cartilage, there is this and that, but there are some extra structures. Let's spend little time on these extra structures. So on the top, there is a term used, a ligament. What do you understand by the term ligament? It's like a rope which keeps the joint within its place. The second option, meniscus. We talk about it, the fibrocartilage disc. Then articular disc is also the same. Labrum. What is this labrum? Any idea? Faisal, you're raising your hand.
It holds the socket joint in place.
It increases the depth of my ball and socket joint. My shoulder joint, the bone is very shallow. It's not deep. So to make a big deep, a depth, so there is an additional collar, there is an additional rim, that is called labrum. After this labrum, joint recess, there are some outpouchings. And then last thing is Synovial Bursa. Who will tell me about Bursa? Guys, if you give me a wrong answer, I have no problem. We are here for learning. We are allowed to make mistakes. Yes, what do you understand by the Bursa? I'm not saying next to Istanbul there's Bursa. That's a different story. I'm asking here, what is Bursa? Sac filled with a synovial fluid, but for what? Can you say? Speak loud. What I'm understanding, she's saying it has a role in shock absorbing, like you're sitting for last 30 minutes on this chair. If I could have I wish I will not, a solid wooden bench, will you be that much comfortable? On this seat, you're sitting from 8 o'clock, I know. You're listening different speeches, from lab safety to assessment to me and blah, blah. So this cushioning at certain places within our joints, we need cushions. Example was given very nicely. It's a sac of mucous membrane filled with a fluid. So this is a pillow. You know, you sleep. Can you sleep without a pillow? It's difficult. I know there are certain people when they travel, their pillow will travel with them also because they are not comfortable with any other pillow in this world. They love their pillow that much. And I've seen those people. Yeah. I have a picture to show it to you. I know you are still stuck up with that. So Bursa is clear? Yes. Joint recess, I think, joint recess is what? There is a joint cavity. In certain location, it is outpouching. So there is an extra space within the sides. When I have a real example, then I'll be showing you, this is called joint recess. See, a recess is an extra space. Like this hall, there's an extra room on a side. That is a continuation. Like your nose, and in the periphery of your nose, there are hollow bones. So you have paranasal sinuses. They have the same mucous membrane there. So the recess is outpouching. And bursa is, you need to have a cushion thing. You need to have a pillow thing. And that will facilitate, that will minimize the friction. Are we good? Yeah. My dear, do you remember when you are a baby, you are always asking a dad, I want to go and sit on a ride which moves around. There were some horses hanging on the sides. It never happened. I'll take you to some amusement park, but must visit that. There is some ride which moves round and round. We call it merry-go-round. This pivot is a classic example of that. So now, who are the lovers of meniscus? You are looking at a real meniscus. The upper surfaces of my tibia bone, this is the picture which demonstrates that. This light blue structure on both of these are demonstrating my the fibrocartilageous disc, and this disc is a must which has to be present, which has to be active within my knee joint. Are we good? Now, this is where my answer is for you. So now we are looking at the different examples. So what we are looking at here, the labrum. Look at this labrum. So this bone is not enough. So there are some extra processes has been made. Some extra circle has been added. That is called auricular labrum. Now, who was asking about the recess? This is the recess. There is an outpouching coming from a joint. Are we good? Do you understand labrum? Let me show you more. This is a bone. Now the ball is, can a ball stay here? It can fall down. So I add some extra fibrous rim around so that this ball can be deeper. So it can accommodate this head. And the classic example is occurring at my shoulder joint. If I look at my hip joint, there is a well-made socket and well-made ball. So it cannot pop out. But at my shoulder, it's just a flat cavity. So what has been added at its side, there is an extra fibrinous, very thick cartilageous tissue, is a very thick tissue, which is being helping this bone to become more deep. Yes. Synovial membrane is always present where the articulating surfaces are not facing each other. It is always lining the joint cavity, but away from the articulating surfaces. If this synovial membrane comes on the articulating surfaces, it will be killed, it will be rubbed, and it will not be doing what it should do. It is just giving you further depth. It is increasing your area. Example, I think when you'll be coming to the lab, ask me. These are the things which should be shown. And this is an extra pad of fibrous tissue which is attached at the margins of the bone. So this is called labrum. Then look at it. This is the bone. And this dark blue thing is an extra pad which helps this head to be accommodated well. And then you can see here the articular disc. And there you can see the different examples of the disc, and these are the menisci. Excuse. Are we good so far? Now, the structural and functional, same thing which we have talked about. Yeah, this is good. Look at it. This classification tells all about my ball and socket. 3. What is this 3? Flexion, extension, abduction, adduction, and internal rotation, external rotation. And it gives me as an outcome of circumflexion. So my ball and socket, I have how much functionality is there? 3 points. My ellipsoid joint, 2 points. I only have flexion, extension, and laterally I can move. Saddle joint, 2 points. So these are biaxial, multi-axial. And this hinge is uniaxial. Pivot is uniaxial. Modified hinge, my knee joint, which is an extra type of hinge. So it has 2 type of movement. So biaxial. And the plane, only 1, that is single, in single plane. But why I written 3? Because it can go in different direction. It can glide in different direction. Are we clear? Ellipsoid, look, you can do flexion, extension, and you can also do this, abduction, adduction. You can also do, but that is a combination of all these movements. Are we good? External rotation. Okay. For that, you need to have some closed type of things. Look at my shoulder. You can move it a little bit along the longitudinal axis. You can move it outwards. That is external rotation. And when you bring it close to you, let's say I'm putting my hand here. Somebody asked me, show me the external rotation. Look at this joint. There is an external rotation. When I'm bringing it back, this is internal rotation. Are we clear about this? Guys on that side. At this joint, shoulder joint, my hand is here in a neutral position. I'm bringing it outwards. I'm opening it outwards. So that is an external rotation. I'm bringing it inwards. That is an internal rotation occurring where? At my shoulder joint. And who's doing it? Primarily my deltoid and assisted by pec major. They are doing it. Are we clear? So now this is a summary. We talked about it. You can read it yourselves. And this is the time to say bye-bye. And guys, for attendance, if you have any type of glitch, now you have your BLCs. If anybody has a problem in the attendance, write your email to your BLCs and they will forward one complete email to me, not individual emails. Otherwise, my inbox is mess up otherwise. Yes.